I'm going to start with the introductions. We are also just going to describe our backgrounds because sometimes we know we have people all out of sight who join as well. So we want to make sure we're inclusive. But I'm going to start with my name is Chisomu Daisy. I am an economist. Specifically, I practice institutional and development economics. So I love to look at and analyze how systems and structures work. I am also a DEI practitioner and an active student learning and growing and unlearning. I'm also the founder of Diversify, one nonprofit organization that works on four main pillars. So we have health, economic justice, immigration, society and integration, and global inequalities. And I am a Black woman, brown skin, wearing my hair straight. In my background is blurred. You might be able to see the makings of a round clock. I'm wearing round biggish earrings with gold and wood design, I guess. I'm really terrible at this today. I'm wearing a yellow jumper that has a black and white stripe rectangular going down. This is not going so well, but lovely to see you and thank you for being here with us. Amisa, I'm going to toss it to you.
Hi, everyone. My name is Anisa Rahid. I'm so happy to be here. And thank you to all of you for joining us. I come from Nairobi, Kenya. My pronouns are she, her, and I'm a neuropsychologist, counseling psychologist, and a mental health practitioner and advocate. My personal work is around decolonizing and mental health and Africanizing it, sort of, as well as looking into systemic and inequities around mental well-being. Apart from that, I am the founder and executive director at Nivishe Foundation, where we basically deal with community-based mental health interventions from the culturally sensitive lens, as well as using local context and local languages to make sure that there's mental health literacy within the continent. Today, I am a Muslim woman, so I put on a yellow hijab. I wear glasses, and you can see my earrings. I'm also wearing a shirt that has some, if you look keenly, you see it has some drawings. My background is not black, but it's also white behind it. So yeah, I think that description will suit. So again, thank you once more for joining us, and happy to kickstart this conversation. I've been really looking towards it, yeah, for a while.
Likewise. And this session is brought to you both in collaboration with Nivishe and Diversify. So we're just going to jump right into things, Amisa, and I want to kind of start by maybe framing where we're taking this discussion from. So from your perspective and the work that you do, and you've already kind of touched on it a little, but what does health equity mean for you, and how does it connect specifically to mental health?
Thank you for that. So I think for me personally, I think health equity is accessibility of health, right? Because I believe health is a fundamental human right. Like everybody should get access to whichever health right it's there, because I think it's a human right. And when everybody can have access and attain their full potential when it comes to their health and well-being, that is when I call it health equity. So it is the same thing because it translates to mental health. Mental health, again, I believe is a fundamental human right, that there is no health or well-being without prioritizing of mental health. And if we all have accessibility of mental well-being, and we can all defend accessibility in whichever context we are from, but for as long as we have accessibility to that and we are living to our full potential with the when we are mentally healthy, that is how I define health equity and mental health equity. But I would love to hear your definition on each. So what do you think health equity is from your perspective?
That was a really good, I mean, it's quite similar to how I think of it. I think of health equity as ensuring everyone has access to the care and the resources they need to achieve optimal well-being, regardless of their context, regardless of, the systemic barriers that they face. Mental health is so deeply tied to this because inequities in income, inequities in race, in gender,
Mhm.
in sexual orientation, in access to care, shapes, who gets supported and who is essentially left
Mhm.
struggling, or even who is
Mhm.
silenced or completely erased. True health equity demands that we intentionally dismantle these barriers, that we prioritize
Mhm.
culturally competent care and recognize mental health as integral to overall well-being, as not something separate, as not
Mhm.
something to be treated with medicine, but also start thinking around how do we promote health and well-being? How do we ensure that we're looking at the whole person and not ignoring the intersection at which they experience the world? So for me, health equity looks at the full picture. And sometimes to look at that
Mhm.
picture, we need to be able to engage through the discomfort. It's nice to sit there and
Mhm.
say, especially this month where it's Women's Month, we're celebrating all these great
Mhm.
things. But we can't really just celebrate women when we leave trans women, when we exclude them. We can't
Mhm.
celebrate health or Women's Month without looking at disabled women or women who don't look like us.
Mhm.
And even with the intersections, right? You and I can sit here and say, all right, we're both African women, but we need to also
Mhm.
look with nuance and say comprehensively, what does Amisa need to
Yes.
thrive? Which is absolutely different from what Chisom needs to thrive, even though on the
Mhm.
surface will appear the same.
Mhm. I just wanted to add, I really like the point where you said that there is that intersectionality, because when you're talking about barriers to health equity, we have to look into also the economic barriers. We also have to look into the stigma or cultural or social norms, which are somehow barriers when it comes to health equity, because we may have all the services and accessibility to get equal health, but maybe there are social norms and traditions and behaviors that hinders us to access this health, uh, hinders to access health rights. So I just wanted to highlight that I like the point that you mentioned about intersectionality and the nuance that comes within defining health equity and barriers to it. Thank you for
Mhm.
that.
Hmm. Thanks, Avisa. I think I also would like for us to lean into the stigma, but I think we can get to that as well, because that's also
Mm-hmm.
important to unpack. Even where
Mm-hmm.
care is available, I think for many people, because of their identities or the
Mm-hmm.
identities that they carry, they also do not
Mm-hmm.
meet the best care. And sometimes you're afraid to ask for it because there's this stigma I associated with the care that they need. I do want to
Mm-hmm.
ask you, just let's also frame what holistic and culturally competent care is. Why
Mm-hmm.
do you think it's actually important to achieving health equity? And if possible, can you also share real life examples of like where healthcare has failed because it wasn't culturally competent?
Okay. Thank you for that. So for the context, as much as I'm a Kenyan, I come from an ethnically marginalized community. So I'm a Kenyan Nubian, and being a Kenyan Nubian, like when you are basically ethnically marginalized, that means that you're not recognized by your country or your state, to be like you're treated like a second-class citizen. So what happened is that when people from ethnically marginalized communities or other marginalized communities, they get a hard time to get documentations. So it's hard for the people from my community to get things like identification cards. And if I do not get the ID card, I cannot access public services. I cannot access health. I cannot access hospitals. I cannot access bank, because that is the only document that will show that I'm a citizen and I have the right to access these things. So when you're not able to do that, you find that uh, the people from marginalized communities, in whichever marginalization we're talking about, have hard time accessing health services in whichever capacity. So you find that even now, that is the accessibility aspect. Now, even if the what is it called, the services are available, they are not holistic and they are not cultural competent in what aspect. You find that, let's say, in a lot of in Africa, in Kenya specific, most health and particularly mental health knowledge and information and interventions are usually directly borrowed from the Euro-American model. So you find that we in Kenya, even if it does not apply to us, we just take every information, even the medication and everything, and actually allow it, just copy and paste without thinking of all the nuances. Like we do not have the same background, we do not have the same, like we are not coming from the same cultures as where the information is coming from. So you find that is why a lot of mental health interventions in the continent, in Kenya specifically, because I work a lot in Kenya, are more harmful, and they don't tend to actually support people, and they create more stigma because people will say, you are not allowing us to follow what you already know, but you're just bringing us the Western, as they call it, Western version. So when you're talking about something like depression, a typical Kenyan will tell you that is a Western illness. It is not like a Kenyan illness because we have not allowed ourselves to learn from our cultures what is the languages used to even talk about mental illnesses. How have the people been using this type of mental illnesses? When you're talking about culturally competent care, the main mental health intervention that we know of is therapy. And as we are breaking down therapy, let's say, for instance, I work in informal settlements. I work with vulnerable community, marginalized communities. And this is a scenario that happened whereby we used to have volunteers of therapists coming to the community. And then the people who are getting services from the therapists will tell us, we do not feel that this is working for us because this therapist was asking me why I'm living in a single house. Like, I'm there to talk about my problem, but I also have to describe uh, further things which actually leads to re-traumatization. So and I cannot actually blame the therapist, and I actually have to sympathize with the people who are getting the services because there's a disconnect there. And that disconnect comes from our cultures. We come from different cultures. So how do we also make sure that as we're speaking about mental health or well-being, we are not just borrowing everything, but picking what is working. And as you said earlier, Chisom, be willing to learn from our communities the indigenous knowledge about mental well-being or healthcare that we've been using, so that we can use that instead of just bringing in and assuming that these people do not know. So we are the ones to teach them what is happening. Yeah.
Hmm. Hmm. So much to unpack there. Um,
Yes. Yes.
yeah, I'm thinking about, basically what I get from what you're saying is that, holistic
Mm-hmm.
and culturally competent care needs to look at the whole person, their physical,
Mm-hmm.
mental, social well-being, even like their
Mm-hmm.
environment, while respecting kind of things like cultural backgrounds, lived experiences, and unique needs, even when we come from the same context, and I think
Mm-hmm.
this is essential for equity because this one size fits all approach continues to
Mm-hmm.
ignore systemic barriers and disparities, and then it leads to this sense of inadequate care. And I think maybe this cultural awareness is so important, like lived realities, individualized support. And I think that's also going
Mm-hmm.
to be important, creating, individualized care as a way to ensure that we are creating for diverse communities. And something you were saying actually resonated for me around, okay, kind of like where does it go wrong when it's not culturally competent? I know
Mm-hmm.
so many, for example, queer folk or people of color, Black women, myself included,
Mm-hmm.
who had to recover from therapy, right? Because you go to
Yes.
therapy
Yes.
and you are essentially teaching your therapist about your lived experience. And sometimes you have to
Mm-hmm.
defend your lived
Mm-hmm.
experience, and they minimize that experience. So you go to therapy and you come out of it more traumatized. And I think that's also something we need to lean into more. So on one
Mm-hmm.
hand, yes, how do we solve this problem of creating or creating pathways for more people from diverse communities to be, to support other diverse communities in therapy, but also there has to be a responsibility for those who are currently in this space, in this work, to ensure that they're not causing more harm. And this is why, as well, I think this often amplifies stigma and also
Mm-hmm.
amplifies when people don't get help because it's like
Mm-hmm.
I mean I remember like moving to Norway and looking for a therapist, and I think it took me 7 8 years to find one locally, who I could trust, because I go meet somebody, talk to them, I'm like, nah, I'm not about to do this to myself.
Mm-hmm.
And I think there's also that fear of you're not going to get me, so I'm not going to get help. And then people struggle. And I also reflect on kind of like what you said around, what is mental health within the context of where we come from. I remember the first time I had a mental health crisis. Um, and I was wondering, how do I get help? And I share this, because I remember talking to my mom about, like, I'm not doing well. I need to see a therapist. And the first thing she said to me was, why? Are you crazy? What's going on?
Mm-hmm.
And she meant it well,
Mm-hmm.
because it's like
Mm-hmm.
people who need therapy, like something is wrong with them, something is not right in your head. And she's like, you have everything you need. You have a house, you have food, you're in school. What do you need? And of course, in the next breath, she was looking for a therapist. But that stayed with me for the longest time because it amplified the sense of stigma. Like I was a failure, that I didn't have myself together, that I needed somebody else to help me. And I
Mm-hmm.
think there's also something to unpack and unlearn from that. Like I've had to heal through that, even though she
Mm-hmm.
actually did provide me with the support that I needed. And then thinking of that privilege of getting that support. But then for some people, it just ends at you're crazy. Like, what's wrong with you? What do you
Yeah,
have to
yeah,
complain
yeah.
about?
Mhm. And also, one thing about lived experience nowadays, you hear everybody's talking about mental health and lived experiences, but what are the metrics to determine who has lived experiences and who comes up with the metrics? Because you'll find that maybe a research organization is supporting mental health research, but they say that we want people with lived experiences, but they decide who lived experiences is, not knowing that me, I can say that I'm privileged because I have mental health literacy knowledge. I know mental health, and I can be able to go and access therapy services, whatever mental health intervention that I need. But I'm imagining the vast majority of the community that we work with, our parents and whatnot, they do not have that privilege to access our services. And if they do, and most of the time, if they don't, we do not allow them to self-diagnose because I know my body better. And I can tell you that I'm not feeling this way and this way. But if I go to a specific let's say a specific doctor or a therapist or a mental health practitioner or just general doctor, what will they tell me? That they're the experts. I should allow them to do their work, not me telling them. Yes, I know my body. So what is also the line of understanding that the people at the community, we know our bodies better. And I do not, sometimes when I tell you that I'm having maybe psychosomatic illness, that if I come to your hospital and you do all the tests, you cannot find in my body, but yet I know that I'm not okay. So
Mm,
does that leave a room for us to allow people to self-diagnose and say, this is what I'm feeling, and if I'm not going to get the necessary support, this is what I can do? Because a good example is currently in the continent, especially for Black women and women from low middle income countries, you find that there's high increase of autoimmune diseases. But since there is no research to actually combat and say, okay, there's high increase of these autoimmune diseases, we do not prioritize it and we do not accept these women are going through autoimmune diseases. So we'll bundle it under other illnesses and try to cure other illnesses.
mm, mm.
allowing people with experiences to not only be diagnosed by practitioners, but they leaning into the indigenous traditional knowledge to be able to say, I'm not okay, and
Mm,
this is what I bring on board. Yeah.
mm, mm. I think that brought up for me as well is kind of like the gaslighting that happens in care. And
Mm-hmm,
yesterday I was actually speaking on another event around health, maternal health and health
mm-hmm,
equity. And
mm-hmm,
when you talked about research, what came up for me is kind of what I shared yesterday as well around like the importance of reclaiming data and narrative power because
mm-hmm,
it's going to be important for actually bridging the gap because it is true that who collects data, who controls it, who interprets it, actually determines what gets prioritized. And there's a decolonization and a re-indigenization of data that
mm-hmm,
actually needs to happen, one that centers, like lived experiences and, focuses on how do we redefine what good health is? How do we
mm-hmm,
redefine what appropriate or adequate health outcome is? Because again, as you said earlier, there's this dominance of Western, Eurocentric, and to be honest, just white medical
mm-hmm,
models. And it tends to impose this very narrow perspective that often pathologizes the view of health, and it
mm-hmm,
tends to prioritize, biomedical solutions. So basically, like treating illnesses rather than actually focusing on health promotion and prevention of like bad health. And it basically discards indigenous approaches because hey. 10 people have not written about it from Europe or from the West.
mm-hmm,
It's not relevant, it's not important. And I think this emphasis, because I see a lot of solutions globally, there's this strong emphasis on curing illnesses. And we need to
mm-hmm,
really, how do we go back to a salutogenic process that focuses on building agency and making life meaningful, for people? Because when we continue to erase the need for this holistic access to care, um, or care that is culturally rooted, it leads to a lot of misdiagnosis, like you talked about. I think it also amplifies, stigma, and it
mm-hmm,
also leads to inadequate care. So again, we're just solving symptoms rather than like the root causes,
mm-hmm,
you know,
mm-hmm,
of problems. And I think like this global health equity conversation also requires us to value diverse knowledge systems,
mm-hmm.
that rather than just imposing this very Eurocentric method as like the goal. And with that, I do want to ask you about, specifically the work you do at Nivishe Foundation.
Mm-hmm.
Um, how do you actively engage with care while challenging or dismantling these dominant models that are often inadequate?
Okay. I actually wanted to just, before I jumped to answering your question, the aspect of pathologizing, there is also that which we can talk about it is how often, because there is misdiagnosis and all those kind of things, for certain communities and certain demographics, instead of just taking the time to actually try to learn what illnesses is coming up in that community and finding how we can be able to support it or prevent it, we find that we actually generalize. Let's say for some communities, you find that we over pathologize. So if kids in these communities grow up and they're just kids, like they're acting as kids, they're overactive, they're hyperactive, they're doing all these kind of things. So instead of saying, maybe they're just being kids and it's not an illness, but we find that we over pathologize and say, okay, they're neurodiverse without thinking clearly, okay, this is how kids in this community or demography actually, this is how they behave, or this is their cultural context of being kids, but because there's a standard metric on how kids should behave. So if they're not behaving according to this uh, white male-centered version of how kids are supposed to behave, then everything is wrong. So how do we do that? Coming to women, you find that as an African woman, if I do not like know how to control my emotion, or I'm not allowed to express my emotions, I'm not allowed to be angry, I'm not allowed to say that I'm dissatisfied and all those kind of things. And if I do, I'll be pathologized and be told that you're this because maybe it's an illness or it's because of something like that. So also, how do we, and that is part of the colonization and re-indigenization, because how do we make sure that you see me for who I am, and instead of generalizing, having that intentionality in trying to find out what am I going through and how does it play in this? Coming to Nivishe Foundation. So at Nivishe, we are really focused on community, and our work is learning mostly from the community, and learning and relearning the work that we do around mental health. And our work is basically culturally sensitive. So some of the work that we do involves trying to generate mental health knowledge and making sure that the languages used is actually understandable by each and every person. So when I'm going to talk about mental health to the community, I'm using local languages and local context that they can understand. I'm not going to use those case studies and DSM-5 words and try to work with the community level, but how, if I'm coming to talk about, let's say, psychosis, how can I be able to break it down so that a person in the community can tell me, we also experience this, but for us, we usually think that psychosis is attributed to spiritual issue and what issue. So how also can we find the nuance between, yes, mental health, physical health, and spiritual health at the same time, and make it work for people? Because you find that the Euro-American perspective of mental health most of the time does not include the spiritual aspect. So it is usually just scientific diagnosis and scientific because it's data and research. That is what we use. Other things like spirituality and whatnot, because you're not able to substantiate, we are not going to take it into consideration. So how do you also learn from it? So one of the things that we do like massive community outreaches, creating mental health literacy, which will help in help-seeking behaviors, reduce stigma, and create more mental health awareness when it comes to matters mental health. We also have, when it comes to that, we also have started our own first ever comic book, mental health comic book, using again local languages and local context to storytell mental health, because there's so much stigma and mental health is seen as this thing that it's big. So how do we make it into simple context and tell stories so that when I'm reading a story, I can say, okay, that person went through PTSD or through this, and now I'm able to identify through it. The other thing is working with diverse communities. Like we work with imams, we work with all people, just to make sure that we understand their context and get through the gatekeepers of communities, so that at least we can get the access to communities and learn from them. So we do a lot of work, and thank you, Chisom, for bringing that out, because sometimes we forget that we are actually doing the work that involves us breaking barriers to health equity.
Absolutely. I think it's so. I think that the angle you talked about as well, spirituality, for example, like local cultural norms. I think those are so important. And I see like in mental health, in when we talk about mental health, especially in like low to middle income countries or like in emerging market countries, it's also often shaped by like poverty, conflict,
Mm-hmm.
systemic underfunding, for example, and of course the stigma you talk about. And I think like a lot of communities lack access to basic care, and even when those services
Mm-hmm.
exist, they are often, as you say, as we know, Western centric, overlooking culturally relevant healing
Mm-hmm.
practices. So I'm thinking like in terms of like concrete actions that could happen, we can look at it from a policy perspective, and how do we integrate mental health into, say, primary healthcare and social policies that also recognizes like local
Mm-hmm.
needs. I'm thinking of funding. Oftentimes there is funding centered around like
Yeah.
short-term aid rather than, focusing on sustained investments in communities based on mental health infrastructure. So that also needs to be nuanced. I think as well, there's something about
Mm-hmm.
shifting power to those most affected. So even for those of us who work in the space,
Mm.
that in the spaces that we hold some degree of power, we also shift power to the people. So they lead the initiatives, they lead the program in the way that is, relevant for them. And I sometimes reflect on just how incredibly humbled I am. Oftentimes I go into situations, I'm like, like I have a good understanding of this work. I know intersectionality, I know all of this. But then I often walk into spaces and think, oh well, Chisom, you assumed. You assumed you knew
Mm.
exactly what these folks needed. And there's something incredibly like humbling about that. So I think there's that need to shift power. And I think we also need to kind of like, I think training for diverse mental health professionals
Mm-hmm.
is so important so that we can meet, affected communities where they are. I do also kind of want to lift conversation, Amisa, around uh, uh, um, maybe mental health and kind of how it shows up around different bits like maternal health care, for
Mm-hmm.
example. Um, but first, I want to quickly ask you, because I'm mindful of time, how do systemic inequities, how do you think it shows up for, say, Black and Brown people, maybe in the communities in which you engage? And I also kind of want to share a little bit around maternal health.
Yeah. So just, I think I touched a bit of it in my previous point, but when you're talking about mental health and systemic inequities for specific demographies like Black and Brown women during pregnancy and postpartum mental health care, we find like actually it's historic, but I'll just break it down because I'm being aware of time. Um, Black and Black women bodies have actually not been, a lot of research has not been done on our bodies. So we find that when we are talking about our bodies, especially post care, before care, and even just the normal how our body reacts, you find that we go through a lot that is not discovered. And unfortunately, we are given same medications, which causes more harm or has more effects on our body with the presumption that it will work on us because it has.
Is it just me or have we lost Amisa? Yeah, we've lost Amisa? Okay. So while we wait for her to come back on, I guess I can share a little bit around how I see maternal health and was also talking about this. Amisa, we lost you for a bit. Are you back?
Yes, yes, I was talking to myself actually.
It happens. We've all been there. But I think we got a lot of the gists. I don't know if there's something you
Mm.
want to round up with before I continue.
Yeah, I just wanted to mention on high maternal mortality rates, specifically to Black and Brown women communities, and then barriers again, financial barriers, lack of insurance for community, limited access to cultural competent care of people who understand how our body works. So those are the some of the points that I wanted to mention when it comes to systemic inequities in maternal mental health care. But I would love to learn more from you because I feel like you have more experience on this and more background knowledge to some on this.
Oh, thanks, Amisa. I'm thinking about this because I think, of course, there's a lot we can talk about maternal health care from emerging market context and low to middle income countries. But I think, given the time, I do want to reflect on care. Even in the West, right? Statistically, we see that a Black mom is 4 times more likely to die at childbirth than, say, a white mom. And I think for me, I've also had specific experiences because oftentimes when we look at the data, we look at data that's been collected in the US, data that's been collected in the UK, for example. I'm based in Norway. I have 2 kids, and I've had both kids in Norway. And my first experience giving birth was so traumatizing, where I was in pain, asking for painkillers, for just anything to help. And, my doctor was like, no, no, you don't need anything. You're fine. And I'm like, I'm in pain. No, no, you're fine. And they argued with me. And then, of course, I turned to my husband, who's a white man, and I say, babe, I'm in pain. And he turns to them. He says, give her painkillers. And you're like, okay. For me, that experience was a and not just that, just the way I was treated, I was not spoken to, the midwives. I mean, I was ignored, so to say, that I felt so small, right? And I think it took me 3 years. And I think I'm still kind of recovering from it. Like I still can barely talk about it. That the second time around, when I went in to have my second child, kind of like the first time around, you're writing your birth list. And for my first child, I was like, I want, nice, calming music. I want candles. I want all these lovely things. And the second time around, I'm just like, please ask my consent before you do anything to my body. Please do not make me a statistic. And I think that also takes away the joy of childbirth because I'm there thinking I need to birth this child, but I don't want to die, so to say. And I think
Mm,
we rarely think about like the challenges. And I know this is just my experience in a country where on surface level, it's like, no, we're equal. Everyone is treated the same, and there's not a lot of data collected on this. But if you look at Latina women, if you look at Indigenous women, if you look at Asian, Black, and Brown women, there's also like this idea that, say, people of color tolerate more pain. And when they're asking for help, it's because they're drug addicts and they need a fix. And I don't want to traumatize anyone here, but there's work to be done all around. Is how can we center
mm,
people? How can we see people in the treatment and in the care that they receive? So that's kind of like where I'm at in terms of a lot of work needs to be done. And then if you think of people, for example, in the LGBTQ community who need gender affirming care, who need period, any kind of care, they often are not met with just the basic, decent kind of care that they need. And I think that is also
mm-hmm.
problematic all around. And those type of
Yeah.
things also impact mental health. Like mental health is not just this thing that is siloed, so to say, like it's
Mm.
impacted by everything that happens in our lives and all around us. So yeah.
Mm. I actually wanted to underline the word dignified
Mm.
care because most of the time there is care, but is it dignified that I feel like the care that I'm given is human? I'm treated like a human. It comes with dignity because certain communities, certain demographies do not get dignified care. Yes, they get care, but it is not, most of the time, it is not dignified care. Yeah.
That was the thing about like when you talked about dignified care. I was reflecting on this as well recently, talking about my experience in Norway, where, I recognized that when I was about to birth my second child, I put all the midwives on high alert. So they, I guess in their way, have to overcompensate to ensure that I'm treated well. But that overcompensation just gives me the bare minimum care, like the
Mm.
standard, right? And I think that's also what is dignified. Are you treated like a person? Because there was also so much shame that I came out of my first experience with. I'm just like, Chisom, you're this empowered woman. Why didn't you say anything? Why didn't you stay stop? But sometimes when you're in that moment, you feel powerless, right? And
Mm.
there's something about that impacts and reduces people to dust. And I think, mental health is, one of the challenges we see that people struggle to different degrees. But of course, this is something we need to talk about more. I see like we have some comments, really great comments in the chat. I see here a first question. Maybe we can take that quickly. Um, my view is that in Western context, viewing mental health through Western lenses using Western diagnostic tool can also be barrier in accessing and treating individuals enduring mental health for people from different cultures. However, is culture also problematic as it is a social construct? Yes. Fluid, etc. Where do we draw the line on having a standardized approach? Is that something you want to speak to, Amisa?
Yeah. So, uh, uh, Chisom, are you able to give me like the main pointer for that question? Because I feel like it
I
is
think the
all
main
rounded.
pointer is where should we standardize care? Is there like a line where at least culture can be problematic? Culture is also reason why there's so much stigma associated, for example, with seeking care for mental health, for example,
Mhm,
and then there's also over westernization of it. So where is the line?
mhm. I think the line is allowing people in their context to do what works for them and being willing to learn from these people. Because if you see, let's say from Africa, most of the countries were colonized, right? And there is this conversation around where there is neocolonialism or colonialism never went. That means that for all that period, we have not been allowed to go back to our traditional methods to what, but also at the same time, we cannot ignore data, research, statistics around mental well-being, which has already been done in um, the Western centric approach. So what do we do? I think it's finding the thin line between that. How do we bring the community, the model, what they've been doing, their knowledge, the indigenous knowledge, resources that already exist, and how do we also use the existing data researches to make sure that we are putting the two together? Because I feel here now everything is happening and we cannot focus on one side or remove one side completely. The two have to coexist, and it's also just being willing to learn and saying, okay, maybe the community people, maybe school knowledge is not 100% beneficial to some community members. So maybe if we take the indigenous knowledge and they take our knowledge, we can come up with something better. So I think it's the willingness to learn and just and knowing that there's more we can learn from people who are not from our system of education. That's it.
If I can also add to that, I agree with you. I think if I can also add to that, I think the line is in adaptability. Like there are a lot of things we can standardize and it works, but health
Mm-hmm.
is the difference between life or death. So there's no standardized
Mm,
in who should live and who should not. So I think this is why individualized care is so important. Of course, like there are things that we know that work when there is a disease that needs to be treated. There are ways we go about it, but it needs to be adaptable to the different contexts and to the individual,
mm-hmm.
because it's life
Mm-hmm.
and death. It can't be standardized,
Mm,
so to say, So I
mm,
think that's where we need to reflect on it. Yeah, things like we can standardize data sets, we can standardize how we talk about something, but people's lives, people are so unique and so different, and they need different things. And it's kind of also like earlier you had talked about people who are on different spectrums around like whether they're neurodivergent or not. Like I'm neurodivergent,
mm-hmm.
right? And I do know that the way that my specific diagnosis shows up is so different from the next person who has a similar diagnosis, right? Because the way I've learned to move through the world is also based on like the different cultural context in which I show up. So
Mm,
take ADHD, for example. For one person, it could show up in a different way where they're distracted, they're bouncing off the walls, whatever it is. For another person, it could be completely different in how they engage, also shaped by the identities that they carry. So if we're just like, all right, ADHD is treated with this medicine, so go ahead and use it, it might not work
mm,
for that particular person who has a different way or who it emerges in a different way for. So I think, yes, there are blueprints, if you have a headache, paracetamol tends to work or ibuprofen or whatnot, but within your particular context and within something that determines your survival, your well-being, how you think your life is meaningful or not. I think we need to have individualized approaches for sure.
Mhm, mhm. I also saw another comment about care, the last comment on how we need to build our community of care. And I think I love that point on building community of care. But one thing that I'm also learning now, and I think I was talking to my colleague Miriam, she's on the call, with one of my colleagues, and we are talking about how nowadays communities are actually defined. Actually, we are losing what community is and actually forming cliques instead of communities, which are causing more harm again. Because we find that in a community we want to support care, we want to do that. But then in the same community, we find that we ourselves, because we do not understand what communities is supposed to be, and actually who defines for us what community is, because community for let's say my mom is her showing up in somebody's burial or wedding or whatnot, and that is her community. But nowadays there's different definition of communities. So also, how do we make sure that as we are forming these communities, they are more beneficial to us because we know the importance of communities, and we do not end up hurting and harming each other because we are forming cliques which has hierarchies and goes away from what we are trying to dismantle in this world with systemic oppressions and stuff. Yeah.
Mm. I was thinking of even like things I have learned about in the past couple of months that work. There's this really great organization called Friendship Bench, based out of
Mm-hmm.
Zimbabwe. And what they do is they provide opportunities for elders to essentially show up on a bench, sit down, and younger people who are struggling or who have questions with whatever comes, sits with them and have a chat. Like stuff like that goes a long way. People who see you, who can validate your experience, who can even share wisdom. I do agree with, Laura's points here as well. Like I'm in Norway and they're in Finland. I think that in Norway there is maybe two, maximum three, people like therapists as a person of color. And sometimes they also struggle and they don't have communities to, I think it's a lot to carry the weight of so many people who need help and support. So I think also co-creating communities in the way that they mentioned here, and at the same time, in the way that we don't, as you say, Amisa, we do not build it to be exclusive or kind of like a
Mm,
blueprint of who do you have to be, how do you have to engage in the world to be a
mm,
part of this community. I think making it more accessible, like I think accessibility matters, while at the same time protecting the space and the value and the substance and essence of what that community was created for in the first place.
mhm. There was this also a point on postpartum depression and how women and minority go through it, postpartum depression. And I want to link it with what is it called? Not only postpartum depression, but also postpartum illnesses like postpartum psychosis, whereby we find in Kenya, it's just a news whereby you find one day a woman has come and alived herself with her child together. And we are quick to judge because as societies, we assume that as a mother, you have to automatically be nurturing and loving towards your kids, not giving you time to actually process that your body is going through changes mentally, physically, all those kind of things. So that also the little understanding of how postpartum depression works, because sometimes it is expected and you're telling women that you have postpartum blues or something like that, so it is not that serious until somebody is actually diagnosed with postpartum depression. But it links again to the case of community. What we found out with our work at Nivishe with teen moms and young moms is that for those who have communities, like immediately after you've given birth as a mother, and then you have people who are helping you to take care of the child so that you can have your own time, somebody to help you, somebody teaching you even how to take care of your child so that they stop crying, they stop doing that, to be like a mother and to get into the role. If you compare one person who has the such community and another person who lacks such community, you find that the PTS, the postpartum depression in this what is it called, in the one who has community is lesser compared to the one who has no community. So at the end of the day, is it goes back to community and who is there for us, and are we also there for them, and how do we want our community to look like at the end of the day?
I think it's a really good point here that they make, right? I think the comments here is as someone with PTSD. Thank you, by the way, for sharing. And severe mental health issues. Navigating Norway's fragmented mental health system has been a nightmare. There's a severe lack of interpersonal collaboration and coordination, making it incredibly difficult to access the continuous and predictable care that people with complex needs require. Structural and legal barriers further hinder effective support, while long waiting times, a shortage of trained professionals, and poor communication skills among providers only make things worse. So the system is essentially broken, and people who need help do not get the help. And I think this is something that perhaps people all across the world in different countries can also relate to we need better integrated system to support well-being holistically and thoroughly. Because yes, it is true that there are a lot of challenges. Like we can look at it from the maternal perspective. We can look at it from, just say, for example, as an immigrant in a new country, we can look at it from that perspective. We can look at it from a basis of gender, or and also think about for people who are often not considered, say like non-binary folk, for example, within the conversation of what type of care do they get or are they presented with. So I think there's a lot of work to be done. I mean, we're barely scratching the surface in this conversation. And I think a lot of these comments have been really great and spot on. Like we need to talk more about it. And then we need to start pushing for actionable, measurable solutions and policies that actually drive change. So we have 3 minutes. I wonder if there's anything left here. I mean, there are some really great comments as well. Let's see. And John, agree with Amisa. In my community, we have had experience where a woman gives birth to a child with a disability or other physical challenges or changes. The mother ends up being judged and blamed for cheating or sleeping elsewhere, which leaves them in a dilemma with no support yet. I mean, there's a lot of work to be done, and
Yeah.
we create culturally sensitive care that, navigates all this, like a lot of the compounding issues that women face. So if we were to leave people with, like, what are some concrete things, maybe one or two, that people can take with them from this conversation? What would you give?
I think for me would be first the importance of networks and communities, like peer support networks and support groups and communities. So that is very important, because like currently the world is falling apart and we need each other. So that is one. The importance of traditional and indigenous healing integration, with the same time not forgetting the scientific approaches around mental well-being, but prioritizing the indigenous and traditional healing method. And as much as there's work to be done, we are doing the work. Some of us are doing the work. So getting the necessary support in making sure that we continue with the work that needs to be done.
Thank you. And I guess one of the things I will say is health has to be comprehensive. It has to be holistic. It can't just be about treating illnesses. And we need to take that approach, and we need to unlearn, what we think we know about how care should be provided. And we need to always center the people for whom that care is designed for. We not just center them and say, hey, come to the table with predetermined solution, but actually say, hey, what do you need? And how can I enable you to get exactly what you need? So just centering the leadership of those most affected by whatever we're solving for is a way forward. So with that, I want to say thanks to everyone who joined. Really appreciate your time. It's a difficult time in the world right now, so we appreciate you spending your hour with us. We appreciate each and every one of you. Thank you. And thanks, Amisa, for being here. Really good to do this with you.
Thank you. I really enjoyed the conversation.
Likewise. All right. Thank you all.